Welcome to today's Power of Knowing webinar, Aging in LGBTQ+ Communities. Understanding comes from knowing. As we age and as we face illness, our life journey can shape our experiences accessing and using healthcare resources. LGBTQ seniors face unique challenges and needs as they navigate their care options. This webinar will explore the impact of cultural devaluation and discrimination of LGBTQ+ persons in an effort to reveal the role care providers can play in creating inclusive and safe places for aging LGBTQ+ patients and clients. This free webinar is part of a series called The Power of Knowing, created by AuthoriCare Collective, which empowers people to be active participants in their care journey, enabling them to live on their own terms through personalized support for mind, body, and spirit. To get us started, please welcome our moderator, Risa Hanow. Risa serves as clinical and community educator at AuthoriCare Collective and is also a member of the Cone Health Ethics Committee. She is a licensed clinical social worker. Risa, I turn it over to you.
Thank you, Paul. It is my pleasure to welcome our panelists for today. First, let me introduce Ann Arndt. Ann is a retired licensed clinical social worker with extensive experience working with individuals and families. She spent 15 years with Transitions Life Care, providing direct services to patients and families, program management, and end-of-life education. She joined SAGE as a member of their housing initiative, which helps to explore affordable housing options for LGBTQ+ seniors. And she also has served as a co-facilitator of the Education and Training Committee. Welcome. Our next panelist is Mary Manley. Mary is the Director of Growth and Provider Relations with us here at AuthoriCare Collective. Mary is a native of Greensboro, North Carolina, and is an active participant in a number of senior citizen advocacy initiatives. She is currently a member of the board of directors for Elon University Anatomical Gifts Program and understands personally and professionally the value of advanced care planning and what excellence in end-of-life care means to both patients and their families. And Joe Wheeler. Joe is the president of a consulting company in Raleigh. The company specializes in organization development, group facilitation, and training with an emphasis on equity and inclusion. He is the coordinator of the program planning team of SAGE Central North Carolina. And SAGE is an organization which Joe will share some about, but he provides advocacy and education related to the needs of LGBTQ+ older adults. Joe has presented in many different settings and is passionate about providing education and advocacy for LGBTQ+ seniors. So welcome and thank you. We also want to welcome you, our participants. This is going to be a wonderful webinar, and we want to know a little bit about each one of you. So if you could take a moment and complete the screening tool, the question. This is our way of being able to find out a little bit about you. It is multiple choice, so please select all that apply to you. We know many of us serve many different roles. We might be patients and caregivers and healthcare professionals, certainly human service professionals, spiritual care guides, advocates, and other, perhaps something we have not captured, but we appreciate you taking a moment and letting us know a little bit about you so we can feel more connected in this virtual world that we are in. So as we look at the results, we can see we have a number of healthcare professionals, and we appreciate that. We always want to share, and a large number of advocates and human service providers and caregivers and others. I'd love to learn about others so we know to expand our list. So thank you for participating in that. I also want to invite you at any time to make use of the question and answer area on your Zoom screen so that you can send us a question and we will try to answer as many of those as possible during our webinar today. I also want to note that you'll probably hear some resources mentioned, and we will be sending an email after today's webinar, and that will have links to the different resources we mentioned. So don't feel that you need to be taking notes during the webinar. We'll be sending out that information. But I think to get us started, Joe, if you could give us an overview of SAGE and then really help us understand a broad overview from a historical perspective, and then the current state of where we are in terms of the unique challenges and the needs of the LGBTQ plus older adults.
Thank you, Risa. So first of all, I want to say thank you on behalf of SAGE to be able to partner with AuthoriCare and the panel that's going to be next week, also with AARP and with Duke Healthcare. So thank you for this opportunity. SAGE Central North Carolina is an affiliate of SAGE USA, which has been providing services and advocacy for LGBTQ folks from New York City since 1978. We are one of 29 affiliates around the country. It was 2 years ago that we transitioned from being SAGE Raleigh to SAGE Central North Carolina. And for those of you who are here from the Triad, know that you're going to be hearing some more about our programming as we expand programming into that part of the state. So I see that my part in this panel is to provide what I think of as a historical or a cultural perspective of the experiences of LGBTQ folks who are in their 60s, 70s, and 80s, and 90s. And for me, that starts with a premise that in our society, we have dominant populations and subordinated populations. Dominant population, white; subordinated population, people of color. People who have who have an immigrant status, people with disabilities, etc., would be subordinated populations. And I argue that LGBTQ folks, compared to our heterosexual colleagues, are a subordinated group. I also have the premise that subordinated populations often know a lot about the dominant group, but the dominant group often doesn't know a lot about the subordinated group. And so there have been aspects of our culture, of our context, that I think may have had a huge impact on who we are today as older LGBTQ folks and how we enter the senior services community. So that's my job. Other folks will be talking about solutions. My job is to talk about what got us here. So first of all, when we were young, we heard the word queer. We may not have known what it meant. We knew it was bad. We knew that we were looking at the wrong pages in the Sears undergarment catalog. We knew that if we went to the library and we looked up or we found a book surreptitiously around homosexuality, it said that we were mentally ill. And as we became, at whatever age, understanding our own sexual orientation, we knew that we were outside the norm. We knew that we were somehow considered less than our heterosexual peers. And in 1973, now I was 22 years old in 1973, the American Psychological Association, based upon their current research, determined that being gay, being homosexual, should no longer be considered a sociopathic personality disorder. Though I'm guessing that that did not change therapists' approach a whole lot. People who were transgender, the APA assigns a diagnosis of gender dysphoria, which can reinforce the stigma of being transgender. Now, no matter where we lived, our primary outlet of places to collect in our youth was around bars. Often they were without signs, down an alley, and we ran the risk of being rousted by the police who might take our information and threaten to notify our employer. In 1950s, in New York City, they had a law called lascivious carriage, and you could be arrested for the way you walked down the street. If anyone found out that we were queer, we risked being ostracized by straight people, of losing our job, of being forced out of the church, of being discharged from the military, and even our physical safety could be threatened. As I have talked to other gay men, many of us have had the experience of someone shouting a slur or something threatening to us from a car window. And so we began to have our antennae were out to the environments that we were in, not just for our emotional safety, but for our physical safety. Part of that is that we developed coping mechanisms where we could hide the part of ourselves that were important to us, except when we were around other LGBTQ people who became our community, our families, and our support systems. Now, when you think about role models, we had movies like The Detective with Frank Sinatra and Lee Remick, where a gay bisexual man commits murder and then suicide. Or we had The Sergeant with Rod Steiger, who committed suicide. Or we had The Children's Hour with Audrey Hepburn and Shirley MacLaine, which ends in a funeral. I sometimes say that The Boys in the Band, and the film came out in 1970, was a breakthrough film because at least in that film, the gay men did not kill anybody and they didn't die. They only went on to live miserable, gloomy, despondent lives. Now, in the 1950s, Christine Jorgensen made international headlines when she transitioned to being female. But other than that, people who were transsexual or transgender were largely invisible. In the 1980s, we realized that people, primarily gay men, were getting sick and dying of the disease called AIDS. It was originally called GRID, Gay-Related Immune Deficiency Syndrome. At that time, people who lived 24 months or more were considered long-term survivors. But during that epidemic, our community began to come together. And one of the things that we experienced that was important to us is that many lesbians stepped forward to provide caregiver support along with gay men. We were taking care of our own because the federal government resisted giving much attention to it. And wherever we lived, community-based organizations grew up to provide services for people with AIDS. Now, our attorneys have advised us to get durable power of attorney, medical power of attorney, and wills, of course, but we were also advised to carry those documents when we traveled because we heard about people who were denied access to their loved ones, for example, in emergency rooms, because they were not considered to be family and couldn't produce the requested documentation. In our church, we were told by straight people that we could not be a good Christian. We were told that we could not be a legitimate member of the military. We couldn't be a good parent, and we certainly couldn't be teachers because we would have an undue influence on children and we were predatory. So what we did was we chose a family of LGBTQ friends who validated that we are worthwhile and that we are valued, and our social life centered around our local LGBT organizations. In 1993, Don't Ask, Don't Tell was implemented to reduce the pressure of LGBTQ people in the military. But then we found out that more people were being discharged from the military under Don't Ask, Don't Tell than the previous policy. In the late 90s, states like Hawaii and Vermont started passing domestic partner benefits. In 1994, Massachusetts became the first state to approve approve marriage equality. And California at that time, the courts approved same-sex equality marriage. And then the people voted and marriage equality was overturned, and what was legal was then illegal. Then in 1996, the Congress passed the Defense Against Marriage Act. The United States Congress passed the Defense of Marriage Act, which explicitly stated that legal marriage could only be between one man and one woman. Now, We've also seen, and I want you to think about this, that our rights have been determined by the Supreme Court. And someone once said to me around issues related to people of color, that if you've never had to have the Supreme Court determine if you have basic civil rights, that is a privilege that you have. For us, there was a point when the Supreme Court approved being able to arrest us for having sex in our own homes with someone of the same sex. That was overturned by Lawrence versus Texas in 2003. And then in 2015, US versus Windsor overruled the Defense Against Marriage Act. In 2014 was when marriage equality became legal in Raleigh. In that year, I told my husband that I wanted to marry him on the date of his birthday because that was the only way he would ever remember our anniversary. And it turned out we got married the day after because one of our witnesses had a Pilates class. Go figure. So that's some of the context that we've lived in. Now, I've talked largely about institutional, but there's also the interpersonal homophobia or heterosexism that we sometimes experience. And I'm going to give you just a couple examples that have come to my attention recently. One of our SAGE members moved here from a large city. The first week he was here, he needed some help with his partner who had Alzheimer's disease. He went to the next door neighbor and said, I need some help. And they said, are you his caregiver? And he said, no, I'm his husband. And from that point on, his neighbors have refused to speak to him. So when people come to SAGE around having a community of other LGBTQ folks, it's often because we don't have the experience of having emotional or physical safety in our own environment. Now, that's the cultural piece, that's the background, that's the context, and other folks are going to talk about some of the impact of that. Thanks, Risa.
Thank you. That was really, I think, helps us have an understanding that many of us may not have, or helps us put into context as we continue our conversation. And I want to turn to Anne. And so thinking about all that Joe has shared and thinking about the individual person or that family of choice and when care is needed. So what are some reasons that, clearly people shy away from seeking care, and some of the fears and some of the challenges that are faced by our LGBTQ plus elders? And talk to us some about that individual experience of people and how that might feel and how that experience is.
Thanks, Risa. I'll share with you, I was reading a book a couple of weeks ago that has absolutely nothing to do with what we're talking about, but the line just jumped out at me, and it so speaks to the experience that LGBTQ elders are going through. And the line was, now how horrible it must have been when the boy realized he was gay and destined to a life of judgment. And despite all of the things that Joe has talked about, all the changes that have taken place, those fears are still there. And people who grew up in the 40s, 50s, 60s, that's what we lived through. And we were sinners, we were insane, we were degradation to society, whatever it was. And that history goes with us despite all the changes that have been made. And you can't get rid of those. We all know that you can't get rid of those. And despite the fact that people may have become more open as society has made some changes, when you become older and more vulnerable, those fears come back again. I think we share many of the same concerns that any other elderly person considers. We're having health issues. Who's going to take care of us if we need help? Where can we live? Do we have the money to pay for care? All of the kinds of things that everyone else considers, but then add on top of that our history, that fear of being rejected, the fear of being discriminated against, the fear of violence. we all want to fit in. We all want to be a part. We all want to feel safe. That's just a greater challenge for an LGBT elder to find that place where they're going to feel that way. And I think that fact that we can't get rid of that history, that's true of all of us. But when it comes into play for us, we still are having to make decisions about how much we let people know about who we are. And that part of who we are is such a core for us. And to have to decide, am I going to let this person know? Am I going to be able to share my stories? Can I share my life? You know, when somebody said to me once, I remember, did you have a nice Christmas? And, you know, who did you, you know, what did you do with your husband? And I said, I don't have a husband. I shared it with my wife. And I had to instantly make that decision. Am I going to let them know that piece about me? And, you know, what we're looking for is that support. We all need that. And the older we get, the more support we need, whether it's emotional support or physical support, whatever it may be. We don't have the traditional network that a heterosexual person may have. You know, we can't necessarily count on our families to be there. You know, many people have felt rejected and abandoned, and they're become disenfranchised from their family. So Joe mentioned about the social networks that we've created and how we have to have that. That's part of what we need to do to kind of create that space that feels safe for us, and that we know we're going to have somebody there for us. I think one of the saddest stories that I remember was a woman who was in her 60s, and she had lived with her partner for over 30 years. And the woman developed cancer, was admitted to the oncology unit, was actually terminal at that particular state. She had advanced care directives where her partner was the one to make her decisions, but they had never let anybody know. They were both school teachers, had never let anybody know about their relationship. Everybody thought they were just roommates. And so when she came into the hospital, the family was there as well as the staff, and the staff was very cordial to her partner, who they thought of as roommate, but they really gave special attention to the family members, and the family was given that time to spend quiet time with them. They were limited the number of visits they could have, so only a certain number of people could go in at a time, and they made sure that the family had that time, but nobody made sure that her partner of 30 years had that time. And she did not get to spend those last precious minutes with somebody she loved because of just assumptions that people made, and those things were not honored. And isn't that what we all want, you know, kind of in those last moments of our lives, to know that, you know, we can spend that precious time there. You know, and I think, you know, we talked about, I mentioned families can become estranged, and that can also come into play where, you know, if you don't have proper documents, and we mentioned living will, healthcare power of attorney, those are so important to have, because if you don't have them, when you become older and you're not able to communicate, they automatically, if there's not a designated person, they automatically go back to the family. And so particularly if there's been an estranged family, they may not allow them to be, their loved ones to be a part of it. I remember a woman who didn't have documents, and her wife had gone in, or they were partners, they weren't married, had gone into a nursing home, and the family came back into her life and refused to allow her partner to be a part of that life with her. So that whole part that, you know, we're always making choices about who do we let know. And if we don't let people know, I remember a woman in Sage who had been a very active woman. When she became older, she needed to go into an assisted living facility, and she had to weigh this, do I let people know who I am or do I not? And because of her fears, she decided not to let them know in the facility who she was. And so she wasn't having visitors. And she looked very hard to find somebody that she felt safe with. And she finally identified someone on the staff who was also gay and was able to share with them her sexual orientation. And he then got in touch with Sage so that we were able to put together some visits for her. But if that hadn't happened, you know, she would have not had that support. I think we also make assumptions. We're human and we make assumptions. We make judgments about things as we see them. And I know Joe and I have both had similar experiences where the person we are a different age of the person that we are with. And I can remember being asked if my partner being asked if she was my daughter. And that doesn't give credence to what the relationship really was. And then we're having to go into that explanation and not know what people are actually thinking. You know, if someone has children, a normal question, you know, where's your husband? Where's your wife? And not assuming that it could be a different kind of relationship. And people, you know, I love older adults, but we tend to be a little more honest than maybe we should be, or a little more out there when we should be. And, you know, I heard of a couple in a facility who they would hold hands, they'd walk around holding hands. One was in the facility, one wasn't. They'd hold hands, they'd kiss each other when they, you know, came to visit. And behind their back, they heard somebody say, I wonder who's the man, I wonder who's the woman. I mean, those are things that, you know, they don't have, other adults don't have the same filters, older adults, that we perhaps have. But, you know, the staff can also get involved in making assumptions. There was a gentleman who, because of his financial situation, he had to room with another gentleman in a assisted living facility. And he was not out to the community or to the staff, but because of the visitors he was having and other things, people were suspecting that he might be gay. And his roommate accused him of inappropriately touching him. And rather than looking at the whole scenario and finding out what really happened, the facility assumed that what this roommate had said was true, and the man was abruptly asked to leave. When the situation actually was not true at all, but they didn't even bother to look because they made an assumption. You know, and I think the decisions that we're making really impact on our looking at the quality of care. That's one of the things we all look for, is we want a place where we're going to feel safe, where we're going to feel accepted, where we're going to feel supported. Even within the medical community, one of the things we know about LGBTQ seniors is they may be more hesitant to come out to their healthcare providers. They're afraid, they've heard stories, or maybe they've experienced it themselves where, you know, their care has been compromised in one way or another. And it's important that they take that step, because the consequences of not doing that, for example, with a transgender person, if they're not open with their medical caregivers, you know, they may be conditions that may be existing that they're not caught because of gender specific situations, which when you look at someone from the outside, wait a minute, you know, this is a man facing me. How could I look at possibly having ovarian cancer because it's a man? And if they haven't told that, then that's apt to be overlooked. There's also the risk of having treatment being delayed. I know a woman who had digestive issues for a good year because she was afraid that she couldn't find a doctor who would be supportive of her. She didn't go to the doctor until finally she had no option because she was no longer able to keep food down. And unfortunately, the woman died 2 weeks later because she had waited long enough to get care. They also, you know, are afraid that the kind of care that they're going to get isn't going to be at the same level that everyone else has. I remember a family who was concerned about their wife in treatment in the facility, and she hadn't had a bath in 2 weeks. And when they finally addressed that, the reason the facility gave was the aide that normally works with her is afraid to touch her because they know she's a lesbian. And a gentleman whose husband had medication errors. They always waited extra long to come when his bell rang. He was in a soiled diaper for a long period of time. They had removed the catheter and violently replaced it. Those were some of the quote accidents, because that's how the facility explained them all, that these were accidents that he was aware of. And he ended up having to stay 24/7. So he made sure his husband had the care he needed until they could find another facility to go into. You know, they've experienced verbal and physical harassment in their life in the past, and they are afraid that this may come back to them. I mean, I think when we look at staff and when we look at the residents in a facility, when they go into an assisted living facility, they're going into other older adults who were part of that generation that was doing the judging back then. And while they may have come to different understandings today, they're talking about older people. It goes back to some of those same things and kind of that inappropriate behavior. You know, I remember a couple that used to, you know, hold hands in the facility, and I heard people and they reported to me other people making derogatory or humorous statements about them. And the facility's response was, well, then we have to stop them from doing that. So rather than helping the other residents understand this, no, that's not appropriate. So they have to stop. Another case where a man was verbally assaulted in a public area when someone found out he was gay. Another resident verbally assaulted him in a public area, and it really wasn't addressed by the facility. That was no wonder we're afraid. You know, no wonder we're concerned about things like that. Joe had mentioned transgender, and I also remember an incident where a transgender person had been in an accident and was brought into the emergency room, and they had not had reassignment surgery. And when they removed the clothes of this, it was a woman, a transgender woman, they found genitalia, and the emergency room staff went kind of crazy about all of this. And that's a lot about looking at how you respond. Yes, it's a surprise, but looking at how you respond to things like that. Showing that kind of respect, it can be something as simple as, you know, we have pronouns. What pronouns do you use? What names do you call people? I remember working with someone who had a woman, she was a lesbian, her legal name was Joan. She had been called Rusty almost her whole life. She was now 80 years old and had dementia. She moved into an assisted living facility, and the staff insisted on calling her Joan. And poor Joan didn't know who they were talking to more times than not, but they never made that change. And when we talk about transgender people, you know, sometimes it is a facility or a care provider will insist that they use the legal name, which perhaps has not been changed. So looking at that as well and thinking about the things that we're doing. And I think that the decisions that we're making and how we make these decisions also impact on our access to care. Can we find a place where we're going to feel safe? I know a gentleman who was looking for a facility, and he went with his family, and they very carefully asked questions. They had their whole list of questions that they asked. And one of their questions was, how do you feel about having a gay gentleman in your facility? And they were fine with that. Didn't have a problem with gay people. But of course, we don't have any. Doesn't that tell you a lot? We don't have any. They haven't even made an environment safe where people could come out and tell them, because we know somewhere in that community there were other gay people there. So they run the risk of being allowed to be there. I mentioned, you know, the gentleman who was abruptly asked to leave, but there was also a situation where there were two women who had applied to live into a CCRC, a continuous care community. They'd been given approval to move in. They didn't describe their relationship. It was assumed that they were roommates. When they found out that they actually were a lesbian couple, their admission was rescinded and they were not allowed to move in. So they had to find yet another place. And that was all because of people's uncomfortableness. You know, another thing with finding a facility too is that finances are very different. You know, LGBTQ seniors don't have a lot of the benefits, have not had over the years a lot of the financial benefits of being a married couple, and haven't been able to often accrue the funds necessary to really provide good care. And also they were not part of a married relationship until relatively recently, so they weren't able to act as a couple, and they were not able to share some of the financial benefits. You know, I think I said that what we're looking for is a place where we can feel safe. And when we come to a facility, we're looking for a place that's going to make us feel safe. And what kind of signs are we looking for? We're looking for an openness in the kinds of things that caregivers or facility owners may ask us as far as, what it is that we're looking for. And do they ask, are you married? Well, suppose they're not. That's an uncomfortable kind of situation. Or they assume, like I mentioned earlier, where because there's a difference in age, that this is the daughter, rather than saying, tell me about your relationship, or who's this person you bring with me? Oh, this is your daughter. So they make assumptions. And so a lot of it for caregivers is about taking that step back and thinking for a minute about, what am I saying and how is it going to be understood? And those are the kinds of things that, you'll be hearing a little bit more about, I think, later and also next week, about what are things that you can do to demonstrate that inclusivity, that acceptance that we're looking for, because they're great residents and you really love having us. Thank you, Risa.
Thank you. I think you bring so many examples that many of us personally, professionally, probably can reflect on and think about what was the experience of someone that I may have encountered. Was I as sensitive in the moment? And how can I do different? And how can we all learn together? And one of the things, Mary, I know you are involved in a number of different committees and organizations and have the ability to see some work that is being done, some initiatives, attention that is being given. And I wonder if you can share some of that with us now, which will help us take our step forward with, what is happening to help this situation so that people aren't in the place of struggle as we see and hear about.
Thank you, Risa. And just to reiterate a little bit of what Ann touched on, we know that aging comes with its own innate challenges and fears, like a loss of independence and social isolation, financial insecurities, or difficulty managing everyday tasks. Things like finding the right healthcare. LGBTQ aging adults live with these same trepidations, but as we've learned from Ann and Joe, our lesbian, gay, bisexual, and transgender older adults face a unique set of challenges that aren't widely understood and really aren't addressed in our society. And that lack of understanding is often manifested as discrimination and prejudice, which have a devastating impact on our LGBTQ elders. At its worst, it means that someone will likely spend their last days alone, feeling isolated and unwelcomed. And instead, this should be a time when they're free to be who they are and be with the people that they love or the people they care about. At AuthoriCare, our tagline is "Your story, our expert care." And I think it's important to share this because it implies that as an agency charged with caring for patients with serious illnesses, we're meeting patients where they are. It affirms our commitment to diversity, equity, and inclusion. And it means that we embrace hearing, learning, and seeking understanding of where they are, what they value, and how we can best meet their needs. It's about acknowledging and honoring the uniqueness of our patients. So how do we honor one's story when we don't fully grasp how to accommodate their special needs and circumstances? How do we make progress toward ensuring that the aging and health issues facing LGBTQ baby boomers are no longer disregarded and that they no longer have to live in fear of being discriminated against, ignored, or mistreated because of their orientation? Creating access to person-centered care within underserved communities is really rooted in providing ongoing education and cultivating relationships and developing trust within these communities. And we often make assumptions that are based upon what we think we know about a group of people. Instead, the key is to approach this work with a far more open and inquisitive mind. In terms of some of the resources and access to those resources, the National Hospice and Palliative Care Organization is the resource that most hospice and palliative care agencies nationwide look to for education and for best practices for implementing and sustaining equitable, inclusive, and diverse practices and policies. I'm fortunate to sit on the NHPCO's Diversity Advisory Council, And the council's role is really to help direct the NHPCO's efforts to support providers in connecting with those diverse populations and to devise practical tools and strategies for improving access to underserved communities. And over the past year and a half, the council has been really busy, and working on several very important outreach guides that provide the framework and resources for delivering equitable, compassionate, and supportive care to patients and their families. Last June, in honor of Pride Month, we released the LGBTQ resource guide, and it's incredibly impactful. This is a comprehensive guide that does provide very specific, actionable strategies for LGBTQ education and community engagement. It's free of charge and available to any person or organization committed to adopting more diverse, equitable, and inclusive practices. The resource guide is a very easy read, less than 20 pages, but it's chock full of valuable information and links to a host of other resources. And you can get this, I think we're going to drop the link to the resource guide in the chat. But finally, I would be remiss if I didn't acknowledge the meaningful work that SAGE and the National Resource Center on LGBTQ Aging has done. Their work has not only impacted the lives of so many LGBTQ seniors, but they are who other organizations look to for education and guidance on how to best support and improve the lives of LGBTQ older adults. Thank you, Risa.
Thank you. And we did put that link in to the chat, and also it will be included. Everybody who registered for today will get a follow-up email, and many links to different resources will be included. And we have a question that, Joe, I think I'm going to come to you first on this question. Part of the question is what service providers can do to create safe space and quality care for LGBT elders of color, specifically asking about, we've been talking in general terms of the LGBTQ elders, but specifically elders of color. Any specific thoughts, experiences, or resources?
Yes, thank you for giving me the chance to speak to that, because this is a passion of mine. First of all, the face of LGBTQ people has largely looked like me, only younger. And so when we portray in our marketing materials or in our educational materials, if we want to portray people who are LGBTQ, we can also portray people who are LGBTQ people of color. The other thing is I am an advocate of education and personal development. And here's what I say. You can't do anti-racism work by default. You can't do anti-racism work passively. It has to be action-oriented on the ground. So I'm hoping that people who represent organizations here are advocating in their organizations to do solid anti-racism work, and keep in mind that when you do that, you may need to be speaking of LGBTQ people as well. So that would be one thing. Education, I think, is important, and a commitment. I also am a strong advocate that if we enjoy a privileged position in our culture, in our society, and as a white person, I experience privilege in that area, that I need to do my own work around race and racism. And so, again, I would suggest that each of us take a commitment. This month, Black History Month, SAGE, Central North Carolina, on our Facebook page, if you want to follow it, we are having a different post every day of some icon, some person, either current or historical, who is an LGBTQ Black or African American person. And so part of it is just staying open to our areas that we by default don't think about.
Thank you. And Mary, I want to come back to you in terms of, the mention of the, you use the term DEI, diversity, equity, and inclusion work. Certainly, at AuthoriCare Collective, I would imagine many organizations, or hope many organizations, are doing that work. I wonder if you're seeing, as you're out and about in the community, more organizations doing that work, certainly on the national level, and bringing attention to diversity across the board, not just in one particular area.
That's a great question, Risa. And I'm so fortunate, as I said before, to sit on the Diversity Advisory Council for the NHPCO. And the council itself is made up of hospice representatives from all over the country. And so we are collaborating to put together these materials. But the greatest part about it is we strategize on how to roll these things out, the tools out to the communities so that they can be implemented. And we are seeing that, this work is very intentional. And so we are seeing and hearing more conversation surrounding how to achieve diversity, equity, and inclusion. AuthoriCare has been really on the front lines of a lot of the work in this area. And so we are often asked, where do we start? How do we achieve, an equitable and inclusive environment? And of course, one of the first things that I'll be first to say is that it starts with listening and hearing and understanding and just, embracing the differences among us. And so, yes, I do think there's more. I think people are more cognizant of the fact that LGBTQ, the population, has a different or a unique set of needs, and just learning really on the front end of learning how to address those.
Thank you. I'm amazed at how quickly our time is going. And there's a question, and it's a wonderful question, and we'll be talking a little bit about this next week as well. But from a caregiver, a professional caregiver perspective, how do we even begin to broach the subject? What is a respectful way to have somebody tell their story? How do we ask questions that are inclusive and feel safe and respectful, so that somebody will want to let us in so that we can provide the best care possible?
It's a challenge for all of us, isn't it? Because we're so used to doing things in certain ways. I think, asking open-ended questions and not making assumptions. And I mentioned something earlier about, instead of saying, are you married? Or this is so-and-so, tell me about this relationship, tell me about your life. Getting people to tell you their story is how you'll find out about what's going on for them and what has gone on in the past. And, we're all, I think, asking them questions about, what their experiences were at different stages of their lives. It's a great way to get people to tell us about what's going on. And I think one of the things that I find sometimes difficult for me to do is watching my facial expression, because if somebody tells me something that surprises me, I have to make sure they don't see it in my face. So it's kind of slowing down.
Right. And I think that open-ended, tell me about who was with you and tell me who is important in your life, that suggestion of the open-ended, not making assumptions, and really trying to, I think that takeaway of slow down is probably important, so that we are present with the person and able to really hear and let them know that we're open to hearing their story, that we don't want to put words in their mouth or family members into their family, but we want their story to be told. Joe, as we think about kind of a takeaway, if you would say to this broad group that we have joining us today, we have come a long way and we have a long way to go. What are some thoughts, takeaways, hopes that you have for us?
Thank you, Risa. To start to answer that question, I'm going to tell you that my husband at one point was in a rehab after an operation. And the staff had been trained. And next week, you're going to hear from AARP, and they're managing Dignity Survey. They found that 80% of LGBTQ folks said they would hope to have LGBTQ providers. And if not, 80% said they want them to at least be educated around our issues. But it goes beyond the staff. So I showed up after dinner, and my husband had a new roommate, and the roommate's family was there. So there were like 5 or 6 people in the room. And when I walked in, one of the people said, "Are you family? Are you his relative?" And in that moment, I had to make a calculus. Am I going to say, "Yeah, I'm his husband"? I just said, "Yeah, we're related." Because what I knew is I was going to be leaving that night, and my husband had to stay with the roommate and possibly the family. And so I would say a takeaway is our antennae are always out. Our culture has taught us that. Our interpersonal relationships have taught us that we are looking to see, am I physically safe? Am I emotionally safe? And because of that, here's what I would say to professionals. We treat everybody is insufficient. Because if you say, well, we treat everybody, what that tells me is you may not have thought about the peculiar things that I bring out of my life experience as an LGBTQ person. That means that if you've done your work, I will feel more safe. And part of this is I'm going to relate back to the question about how do we ask about sexual orientation? My answer is ask about sexual orientation. You know, we ask about people's spiritual interests. We ask if they like to play bingo, might they want to do art? And then we don't feel like we can ask people, and not just ask the people you think are gay or transgender or lesbian or bisexual, but ask people in sensitive ways. And by the way, one of the resources that we're going to provide has some information about that. And the last thing I'm going to say around being aware is on your assessments, look and see if the question is, are you male or female? Because if that's all it has, that will speak to most LGBT people, but certainly to transgender and queer people that you haven't thought about, maybe they identify differently than male or female. So I'll stop there.
Thank you. I think that, we've heard a number of times about always having your guard up or always being thoughtful of what am I going to share? How much am I going to share? And there is a relationship, a correlation to how safe you feel or not feel. And certainly, I think as I look at all of our screens, we see putting she, her, he, him, sending some messages in various ways that we are aware, we are open, we are safe, we are wanting to know. And I'm sure there are many ways as both individuals and healthcare professionals that we can do that. And something that I know I benefit from being brought to my attention during this conversation. And so Mary, as we kind of wrap things up for our time today, I wonder what takeaways, I know that you are passionate about the work that you do. I also know that you look for the positive in the work that we do. And so some takeaways and I think what we are looking towards and what you see coming down the care path for us to look towards.
Yes, I am extremely passionate about end-of-life care. And, to me, there's nothing sadder than to think of someone whose wishes aren't being honored at the end of life. And so I certainly encourage, organizations, individuals to explore the nuances of becoming a more inclusive setting or adopting a more inclusive mindset. As the population, as our LGBTQ population increases, along with our aging population, the needs are greater than ever. And so I think there's certainly there's a business case for our adopting practices that are inclusive and are welcoming. We have to remember the historical issues and the discrimination and the stigma that have surrounded LGBTQ communities for such a long time and be sensitive to those. But, in my mind's eye, and based upon the work that we're doing on a national level, I think certainly that we are making progress. And I do anticipate that we will see in long-term care settings, for example, long-term care settings begin to adopt more inclusive policies and procedures. So I'm just very optimistic about the direction that we're going. It's a very slow process. It's one that requires a great deal of commitment from any organization and literally from every single level of that organization. And that's what really makes me so proud about AuthoraCare is that we, committed to doing the work and it's been all hands on deck. And so I think that with organizations as a whole, we're finding that more hospice organizations and end-of-life care organizations are also subscribing to this way of thinking as well.
Thank you. I want to say thank you to each one of you. The work that you each have done, continue to do, the advocacy, the awareness, and really the openness to join this conversation. When we talk about we all have to make decisions, you've made the decision to step forward, to speak to this topic, and really bring information to the community at large. And I appreciate that immensely. So thank you. I also want to say thank you to the participants, because this is not a comfortable conversation for everyone. This is new learning for some. This is uncomfortable, and this is also extraordinarily important and needed. So thank you to everyone who has joined us. I hope that you will join us next week. We are going to be continuing this conversation. Our panel next week will be including Mark Hensley from AARP, sharing some of the amazing work, insightful work that AARP is doing. Sharon Kilpatrick, who is associated with SAGE North Carolina, Central North Carolina, will be joining us as well. She has tremendous experience as a case manager, and we'll be talking about how do we begin this conversation with care providers, and what do we seek out, and what do we look for? And then Dr. Jennifer May will be joining us, and she works with the Duke Transgender Clinic and is a nurse practitioner, and she has a particular passion and research focus around long-term care facilities. So I hope you will be able to join us, because this important conversation will continue, and we will continue to share insights, and also through the follow-up email that will go out, you'll not only get a recording of the webinar if you want to share it with others, but also links that we can share in terms of these resources that we can all benefit from, share with others, make sure that they are known and utilized by all. As we close, I want to share a quote. Michael Adams is the CEO of SAGE USA, and he was recently quoted in an article in USA Today. And what he said was, we're talking about elders who have lived through decades of oppression, discrimination, invisibility, violence, and who have not only survived, but continued to thrive. And with that, I will say thank you again to the panel, to the participants, and for what you each do each day. We look forward to seeing you next week, and I hope that the rest of today is a good day. Thank you.